invaluable tool in dentistry today, which is CBCT, conducted by the Department of Oral Medicine and Radiology, Faculty of Dentistry, SGT University. Today's program will be divided in as follows. To begin with, we'll have the welcome address, then the lecture on the topic Third Dimension in Dentistry. It's no more future, it is present, very much present, by Ms Vijayta Yadav. A short question-answer session will be followed after that. To begin with, she inspires us and keeps the desire to achieve more, palpable amongst us always. A true academician indeed. May I welcome the host of today's program, Dr Suma GN, Professor and Head of the Department of Oral Medicine and Radiology, to kindly welcome the gathering.
I heartily welcome all the dignitaries who have taken their time off from their busy schedule to encourage us with their presence. I extend my deep gratitude to the chairperson, Mrs. Madhubri Chawla, and Managing Trustee, Mr. Chawla ji, for their everlasting support for these kind of academic deliberations. I welcome our Dean, Dr. Akshay Bhargava, Director of PG Studies, Dr. M S Sidhu, all our HODs, Dr. Grover, Dr. Dayashankar, Dr. Anil, Dr. Ritu, Dr. Chinmay. Dr. Aparna is not here. I welcome the KavoKerr group, Ms Vijayta Yadav. She is representing the KavoKerr group. She is the clinical application specialist for KavoKerr group, for taking her time off today and having these interactions with us. I welcome all the audiences and wish you all good participation and happy learning.
Dr. Akshay Bhargava, Dean of our institution. He is always excellent with his words of encouragement. I request you, sir, to kindly address the gathering.
I welcome Ms. Yadav, representing Kavo. Kavo is an excellent group into a lot of things. And of course, also a hearty thanks to the OMR department, with Dr. Suma heading it, and everybody with this team for organizing this talk, and all my head of the departments, and Dr. Sidhu here for being with us, and students. You know, you put a pack of coins here, 10 coins को लगा दो, उसका एक X-ray लेते हो तो वो एक image है, उसको slices में कर दो, you get it into a CBCT. Now if you want to see those slices, that just takes you into more depth. I won't go much because that is not my lecture, but I'd like to say that there were 4 revolutions that are taking place, or which have taken place. One was the Industrial Revolution, the Agricultural Revolution, then the revolution that the world witnessed when the net came in, connected everybody within seconds. And the 4th that is happening right in front of you is the digital revolution. You can't imagine, none of us can, all of you will be having a 3D printer in your house 10 years from now. आपको कोई spare part चाहिए, कुछ चाहिए, आपको company भेजेगी उसकी file and you will print it out, because that will be far cheaper than anything else. What digital is doing, you have no imagination. I mean, I cannot imagine how things are going to be in the next decade, 2 decades. Do you know when the first digital camera came? 1978 or 75. Were you born? No, staff can't say we were not born. So, and today we have everything, even your phone has a digital camera. Kodak is bankrupt, out. They used to supply to 70% of the world, 70% of the world, the films for taking photographs. कभी जाओ अपने पेरेंट्स की एल्बम देखो, शादी की, ब्लैक एंड वाइट में, उनसे पूछना, फिल्म्स होती थी, एक शॉट के बाद ना बार बार सेल्फी नहीं ले पाते थे क्योंकि वो फिल्म यूज होती थी, उसके अंदर 26 या 32 ही आती थी. So it's a very interesting talk. I have a good WhatsApp messages that have come which have awakened me that what's going to happen. And what digital is doing is a standing example in front of you. You take Uber, it doesn't have an office, it doesn't have a single car to its credit, but it's running the largest taxi service in the world. So with this and the world of digital, I would like to invite Dr. Sidhu and of course later on Ms. Yadav to share with you. Go ahead, you will all be having a digital, probably a CBCT in your clinic in the near future. Don't think that you will be able to do with an X-ray. Thank you.
Around 5 years back, I was in Indian Orthodontic Conference at Delhi only at Ashoka Hotel when I read a talk being given on third dimension, that is CBCT, by Dr. Mahajan, who is the owner of CBCT Center, the first I-CAT machine being installed in Delhi, maybe second, third in India. And he gave us a perspective how a third dimension in dentistry is going to revolutionize in next few years. Most of the hall was not occupied because of our narrow thinking. We will never think after 5 years most of the implants would be requiring CBCT evaluation. Most of the complex orthognathic surgeries will be require CBCT evaluation. Most of the airway analysis, 3D analysis cannot be done without CBCT evaluation. And the list goes endlessly as the softwares develop. And I got interested too much into it, resulting into our first thesis getting started 5 years back on CBCT, got published internationally, not once but thrice. So it is wonderful that you are being taught on a most recent subject in dentistry, that is imaging, that also three-dimensional imaging and its applications, how three-dimensional imaging helps us to unravel the mysteries of not only malocclusion but most of the problems of oral medicine, even oral pathology, how lesions which were always visualized on an OPG, we could never see the lingual, we could never see the details, we could very easily see using this type of X-rays, and it is becoming very common now.
May I introduce the guest speaker for today, Ms Vijayta Yadav. She is a clinical application specialist working with KavoKerr group for the last 7.6 years. She is a well-known name in the CBCT education and training programs for dental professionals on the clinical part of the CBCT machines and planning software. She has delivered various lectures and presentations in AIMS, India, Delhi, Oxford Dental College, Bangalore, JSS Dental College, Mysore, etc. She is a successful biomedical engineer and MBA in marketing in the international business. Today she will be taking a lecture on topic third dimension in dentistry. It is no more a future, it is the present. Over to you, ma'am.
Let us start with the lecture with the CBCT technology, which is no more a future. It is present, and it is very much present. Today, almost 80% of the dental professionals are either thinking of or they are doing their treatment plannings on the softwares. As Principal Sir has rightly mentioned that it is a time of digital revolution. And in another couple of years, you will see 100% of the medical diagnosis will be done digitally. There will be no more films in the clinics, in the hospitals. There will be paperless office. There will be paperless clinics and hospitals in coming years. So let us begin with the presentation. I will not run through the agenda. Alright, so I will not read through the agenda. Just give you a basic idea. The agenda is, we'll run through a presentation for another 20-25 minutes where you will understand what CBCT is. What are the basic principles? What is the difference between a CBCT and a medical CT? And what is the difference between a 2D image and a 3D image? And soon after that, I will take you to the actual software. I'll take you to the actual treatment planning tools. So, alright, so let's start with general clinical imaging. Our body has different parts and we need different type of clinical imagings for different type of anatomy. So let's first understand that. For our brain, we have a very hard covering. We have a very protective layer on our brain which is called skull, and for that we need a medical CT to so that the X-rays penetrate through the brain and give you the view, the internal anatomical view, or the MRI to see the soft tissues. For cardiology, we can use CBCT, we can use a CT, we can use ultrasound, or we can use NMCT. For the entire body, we can use a full CT machine, we can use a PET CT which is a standing CT, or different slice CT, 64 slice or 125 slice CT. And for dentistry or for head and neck region, we have OPG machines, we have intraoral cameras, and we have CBCT, which is the latest technology machine. Now, what is a dental radiography? Excuse me if I am teaching you something very, very basic. Here I am not here to teach you anything about the clinical aspects of dentistry. It is all about the software, the technology, because you know everything better than me. I am here just to facilitate you on the software part, on the digital part. So I included this slide just to give you a brief idea how X-rays work, how they penetrate through different anatomical structures in our body and give us an image. So basically the X-ray image is formed by controlled X-ray burst, and X-rays penetrates through the soft tissues, the bones, the air in the anatomy, and maybe the pulp chamber or some liquid mucus. I'm sorry. So when X-rays pass through these different anatomical features, they attenuate. That means they cannot penetrate through certain features completely, and that is how we get a radiograph. I'll show you. There may be air in the anatomy which gives us a black area in the radiograph. Basically, radiograph is an image in different shades of grey, from all the way black to white, and there are different shades. There may be 256 shades which is given by the 8-bit machine. There may be more like 12-bit or 14-bit machines. Then the crown part, which is the brightest part. If there are if there are metals in the anatomy, you may get a more bright part as compared to the crown. Then the root canal fillings, the soft tissues, the bone. So these are the different anatomies. When we are taking X-rays, these different features are present in different shades of grey depending on that bone density. With the CBCT or with any medical imaging or digital imaging, we have this on the paper or on the software. With the help of software, we can measure the bone density, we can measure the length, we can measure the angulation, we can use lot of tools to calculate and to plan our surgery. Whereas on the film, we can see, and with our experience only we can tell how dense is the bone, where is the problem, where is the calcification, or where is the root canal, where is the soft tissues. So this is the difference between a digital and analog system. So let's move on to the next slide, which represents the basic X-ray imaging concept. In X-ray imaging, we require three things. We require a source, we require an object, and a detector. Source is the X-ray tube, a detector is a detector, or you can say a camera, and object is human body. So X-rays pass through the human body and they fall on the detector in different intensities and produce a radiograph. Now there are two types of systems, analog systems and digital systems. In analog system, X-ray machine and human body, they are same. Whereas receptor image processing techniques, display and post-processing techniques are different. In analog system, after we acquire an image, we have the data on the film. Whereas in digital system, when we acquire an image, we get everything on the software. And then we can apply different algorithms to reconstruct that data. We can use different tools to measure different features, different length, angulation, area, volume, bone density. These tools can be applied with the help of a digital system. And you will see it very soon, maybe in another 10-15 minutes from now. Then digital radiography imaging type. There are two types of imaging, intraoral and extraoral imaging. Intraoral, I'm sure you all must have used at least once by now, which is the intraoral sensor, or what we call RVG. So in intraoral imaging, we need an RVG and X-ray machine. These are the two things that we need for intraoral imaging. The RVG go inside the patient's mouth. We place the system at the desired anatomy, and then we shoot X-rays and we get the picture or the image on the film or on our PC. If it is an analog system, we get everything on the film. If it is a digital system, we get it on the software. Then comes the extraoral imaging. The name itself suggests extraoral, meaning outside the mouth. So here the X-ray source and the detector both are outside the mouth. So in extraoral imaging, there are panoramic imaging, cephalometric imaging, and CBCT. So in PAN, you all know X-ray and the detector both are outside the mouth. The system rotates almost 180 degrees around the patient to capture the area between the two the TM joints. Cephalometric, again, it's a single shot image. X-rays comes and puff, you have one image here of the lateral ceph. Either it is right side, left side, or maybe APPA, whatever field that you like. And then comes the CBCT. So the concept of CBCT is the machine rotates 360 degree around the patient and captures the images from different angles. You may say 2 images after every degree. So if it rotates 360 degree around and it takes 1 image at 1 degree, so there are 360 slices that we have. And as Principal Sir mentioned, it's kind of a book or the stack of coins. You have slices, you work with the algorithm, and you reconstruct, and you have your virtual skull in front of you. We will see it very soon in the software. So here comes the 2D and 3D dental imaging. Let's not waste more time on this slide because we have already discussed a lot about 2D and 3D differences. I'll show you in practical. Alright, can you make out what is this? Shadow, right? But with this image, can we make out where all these blocks are placed? There is a human being we can make out. There are some blocks, but we are not sure what is the placement, what is the positioning. Let's see now. Now can you make out which shadow is of which block? And where is the source? Source means where is the light, or where is the torch, where is the sun? We're not sure. Let's see it now. We have a person and 2 blocks. And here is our source. So let's go back and see. With this image, we cannot make out what are the placements. Where are these 3 different things placed? With this either. But with this thing, we can make out, and this is a clear difference between a 2D and a 3D. Alright, so let's see the difference. This is the panoramic image. As we all know, a smiley pan. And what we get with a pan? We cannot get a full mouth series of dental image. No details of maxillary sinus. There is something available, but there is no full details. Inaccurate bone length, because with the 2D system there is always a magnification, there is always a distortion. Inaccurate buccolingual dimensions, because in a 2D everything is on a paper, we cannot measure. Incorrect inferior alveolar nerve proximity, that means the nerve canal. Superimposed anatomical information, hyoid bone, the upper spine, they are superimposed in 100% of the cases. Image magnification and distortion. This is what we get from a panoramic image or a 2D image. Now comes the CBCT. You see it here. We are piling up on the slices. These are the different views that we can get in 15 seconds of the scan. We have our skull in front of us and we can rotate it, we can cut it down, we can slice it, we can snip off unwanted area, and we can do a lot of different things. And with approximately the same dose as a 2D panoramic imaging system gives. And if it is a small scan, maybe 8-second or 10-second scan, the dose is further less than a panoramic image. So with CBCT, what we get is a full mouth series of dental image. We get more accurate measurements because the machine is rotating 360 degree around the patient and capturing the views from all the different angles. So there are no chances of distortion or magnification in the image. Accurate buccolingual dimensions, because we can cut off the slice and we can see it in different corneal, sagittal or axial cross sections. Clear anatomical information, and yes, we discussed no magnification and distortion. Then the 2D image and a 3D system differences. The clinical information is broad in 3D imaging system with a CBCT. Image distortion is negligible. Measurements are accurate. Planning is more accurate, and there are less errors. There are less surprises. The system is very clear. You diagnose it, you do a treatment planning in the software, and go ahead with the treatment. And when you open the flap, you will not see any surprises. Then why do we need a cone beam 3D system today? Why not only a 2D? What are the drawbacks? By now, we have understood the clear difference between a 2D and a 3D. So now what are the drivers? Why the demand of 3D systems are rising now? There are societal drivers. Patients are more aware of the treatment planning, their health. They're more aware of getting a better treatment, and they are willing to pay. They're willing to pay for that. Technological drivers. As it is a time of digital revolution, we all want a paperless office, a film or a chemical-free office, a chemical-free clinic, and of course the time. When we acquire an image on an analog system that requires washing or developing of the film with the chemicals, and that takes time. Whereas if we have a digital system, it is in seconds. Like our digital cameras work, we click it, we connect it with our computer, and everything is on the screen. Similarly, our intraoral systems or our OPGs or CBCT machines, they are connected with the machine, with the system, with the PC, and as soon as the scan is complete, it is there on the screen. It is there for you for the diagnosis and for treatment planning. Without wasting any time, even with the chair-side patient, you can do the planning. And then the benefits to the imaging and dental practice. We have discussed already. There are a lot of benefits. You have more chair side time, you have more time with the patient. Instead of spending time on developing the film or hiring a technician or hiring few people for film development, for chemical processing or for other systems. Alright, so let's have a look at this video. This is a very, very simple depiction of how a CT, a medical CT or a cone beam CT works.
Hey Grandma, I was looking forward all day yesterday to coming to the playground with you today.
Is it audible?
Yes, dear. I thought you might have been. It didn't work out yesterday because I had to go to the doctor.
Why was that?
The doctor checked if everything was okay with me and if I'm healthy. To do that, I had to lie on a table, and then pictures were taken of my body for the doctor to check.
How did the doctor take these pictures?
I have an idea. Come over here. Anna, turn the disc and run around me as fast as you can.
Okay.
There was a great big ring turning around me, just like you're running around me now. Now imagine that there are cameras attached to that ring. And while I'm lying there, they take a whole lot of little snapshots of me.
With a digital camera like the one I got for Christmas?
Something like that. But the cameras are not the same as yours. They take pictures of what's inside my body. The camera is in two parts. The doctor calls one part the detector, and the other part the X-ray tube. The X-ray tube sends signals out, and the detector converts it into a digital picture.
And what does the picture look like?
It doesn't look like the ones you shoot with your camera. These pictures show slices of my body. My body was photographed millimeter by millimeter, and all the pictures together make up a series. They can be seen and checked right away on a screen. It's like you looking at your pictures on a computer right after you shoot them.
Didn't all that hurt?
Oh, no, dear. The people there are really friendly, and the exam is very fast and doesn't hurt at all.
Didn't you get dizzy from all that turning?
No, Anna. I wasn't turning at all. I was lying comfortably, and the X-ray tube moved around me. Come on. Now let's get you an ice cream.
Oh, yes. Drop it.
With the medical with the medical CT, diagnosis of human body is very simple and it is very much possible within seconds. There are planning and treatment tools with the help of medical radiations or X-rays. Detector type is a ring type detector. X-ray tube is high dose tube. The slices that are available with the help of medical CT, they are mainly the axial slices. We get a 3D volume also. Then there is a difference in the contrast, window and leveling, and patient positioning is lying down positioning. Why I am discussing about medical CT is the concept of CBCT is same as medical CT. There is a detector, there is a tube which rotates around the patient, but there are slight differences. Unlike the medical CT, in CBCT, the patient positioning is either standing or sitting. Unlike the medical CT, the slices are not only axial, you will get sagittal and coronal slices also, which are required for dental treatment. Unlike the medical CT, the dose is very, very less. It is less to the tune of 180% less. And of course, the brightness and contrast or the other tools, the the treatment planning tools which are available with the medical CT are mainly for the medical diagnosis purpose, whereas in the dental there are different tools. So let's see the difference. The beam type in a 2D and a CBCT, or in a CT and a CBCT is, in a CBCT it is a cone beam, and in a medical CT it's a fan beam. Fan means like the blade of a fan. It is a 2D straight beam without any volume. We'll see the difference very soon. The transmitted radiations. In CBCT it is 360-degree round, whereas in CT, if we want to image the entire body, it is 360 degrees plus the spiral movement, like there is a body and CT moves like this. So this is the depiction of a CBCT scanning. As you can see, the beam is conical beam with a volume, and there is a round detector or a square detector which is suitable only for head and neck region. That minimizes the dose. The dose is very, very less. When we take an image with the CBCT, the maximum that you can get is 270 or 280 microsieverts, and that too with the machines which uses a very high dose or very high power X-rays, and they work on more milliamperes. Well, this is a technical term. We don't want to discuss this here. Whereas in a CT, the dose is very high. It may go up to 3000 microsieverts. And it is illegal to expose a patient who is suffering, and we are exposing that patient to the tune of 3000 microsieverts or maybe 1000 or 2000 microsieverts. The size of the machine. CT machine is large, they are bulky, and CBCT is very small. The footprint is very, very small. Patient positioning, we know in CT it is lying down. In CBCT it is either standing or sitting up. There are very less artifacts in a CBCT image. If there are metals, if there are there are fillings, or there are braces, there are crowns, the artifacts, the chances of artifacts in a CT are way more than a CBCT. Protocols. With the CBCT we can select different protocols, like if you want a single arch, we can have a 4 centimeter scan in height. If we want entire scan for the orthodontic treatment, we can go for 13 centimeter or maybe 17 centimeter in height. Whereas in CT we always get a full scan above neck, and sometimes we get our collarbones in the scan. Then comes the dose. We have already discussed. Daily natural exposure to you, to me, to anyone is 8 microsievert at the airports, at bus stands, maybe some stations, in pollution. There are some other machines in our offices, in our work area, where every one of us are exposed to the tune of 8 microsieverts in an I-CAT standard scan. I am saying I-CAT here because I-CAT is the name of the product of KavoKerr. I have not mentioned anything about this machine. This is a CBCT machine, so you can say with CBCT the standard scan, which is of 10 seconds, the dose is 36 microsievert. In the fast scan, which is of 8 seconds or 6 seconds, it is 25 microsieverts. In a digital panoramic image, 4.7 to 14.9 microsievert, whereas with the film systems it is 26 microsieverts, and medical CT you can see 1200 to 3300 microsieverts. And very soon in India also, in different parts of the world, it is illegal and it is not allowed to expose a patient for dental treatment at this radiation level. And very soon in India also there will be norms where it is not legal to or it is not allowed to expose a patient to the tune of this kind of radiation. And here are the reference sources from where this data is driven. So that's it about the presentation. This is a typical image of, a CT machine, how a CBCT machine looks like. This is a sitting machine. You may have hybrid standing machines also, where which looks more like an OPG, where the patient is standing and there is an extended arm for the CEF. So this is all about the presentation, friends. If you have any question on this, let us discuss it now, and then we will move to the software part, which is going to be very, very interesting. Any question about anything on this presentation? Yes.
Ma'am, while comparing CBCT and CT, you told us that the artifacts would be less in CT and not CBCT.
In CBCT, they are less.
Yeah, sure. In CBCT, they are less.
Yeah.
But if we use a cone beam compared to a fan beam, which is used in CT, won't it lead to more scattering and more artifacts as a result?
No.
3D beam would produce more scattering of any kind of tissue or the metal objects for that matter.
I understand your point. You're trying to say that when we are exposing the entire anatomy with the cone beam,
volume, yes.
The chances of artifacts would be more. Whereas with the fan beam, we are actually slicing the scan.
Yes.
Right. Well, this is not the case, because in a CBCT there are, in almost all of the machines, there are inbuilt filters, and this was the challenge. You pointed out very nicely. This was the challenge while designing a CBCT with the using a conical beam, and this was counterparted with different filters, which are applied right before the reconstruction. So in CBCT, the technology is like you take different slices and then you reconstruct. So before reconstructions, these filters are applied.
Because
And
this is one of the points we consider for the resolution of the image also.
the filter?
Like the scattering part.
Yes. So with the help of these filters, you will get less artifacts. And there is one more important aspect of the artifact, the scatter artifact, is the dose. At what kV and MA you are operating your X-rays. In a CT, the kV and MA is very I'm sorry, the kV and MA is very high, whereas in a CBCT the kV is only 120 and MA is 3 to 5. That depends on the type of scan. So with this kind of settings, the artifacts are very less.
Okay, and FOV, does it also have any kind of effect on this, the same aspect of scattering and all?
Yes,
The FOV?
that has, because if you select the entire area, there may be more metals in that area and scattering will be more.
So
Whereas if you take a localized scan, suppose you want a scan for implant, so you can take a 5x5 window or 8x8 window of a single jaw or half jaw, and then you can plan your treatments, and the metal on the other side are not exposed to the radiation, so you will get less artifacts.
So will that affect the resolution of the images, ma'am, if we are taking the full FOV and or a small section? So will both the images have difference in resolution taken by the same, consider that we take it on the same CBCT apparatus? So
Resolution always depends on the type of voxel sizes that you select. You can select a 0.125 voxel or the minimum voxel for a full scan also, and you can select 0.125 or the minimum voxel for a small scan also. So there will be no change in the resolution, whereas there is a change in the timing of the scan and the exposure. So this is the difference. Anyone? Any more questions?
which one will have a better resolution, CT or a CBCT?
Definitely CT has better resolution in terms of the grayscale, because the kV and MA, the exposure that we are using are is more. So when the kV and MA, the resolution or the brightness and contrast is directly proportional to the kV and MA. The more the current or the kilowatt, the more brightness and contrast is there.
That is one disadvantage.
We cannot say disadvantage. We don't need that type of resolution. We don't need that type of contrast. And this is only about the contrast, not about the resolution, because with the CT you will get only max to max 150 slices or 164 slices. These are the highest number of slices that you will get with a CT. Whereas with a CBCT, you get 600 plus slices. So you have more details. And in terms of resolution, I mean to say brightness and contrast and crispness of the image, which is there in the CT, because we are exposing with more radiations. Any more questions, or shall we move on to the software part? Alright, if you guys have any more questions, we'll discuss in between the software discussion or maybe after that. So this is a reconstructed image we get in axial, sagittal and coronal cross sections, and we have a volume also. As soon as the scan is complete, within 15 seconds, this view will appear on your screen. And you have now everything in front of you for the diagnosis, for the treatment planning. Now in different treatment planning softwares, we have different tools. We can slice all the way from 1 centimeters to the entire anatomy. We can cut down in axial, sagittal and coronal cross sections, and we can flip the scan. We can cut unwanted anatomy, then different type of measurements. We can create videos out of the software. What we are planning, we can create a video and we can show it to the patient. So let's move tool by tool. There are different tools, like there are volume rendering tools, there are implant planning, there are restoration planning tools, superimposition, 3D Ceph analysis tools. So let's move one by one. So right now we have our axial, sagittal and coronal scans. And with the scroll of a mouse, as you can see this red line here. I'm scrolling from bottom to top. We are on the maxillary jaw now, and we are now all the way up to the sinus. So here we have our volume. We can rotate the volume also. We can see it from the back. And suppose we don't want anything in this volume, we can cut it down. And these tools are available in different fashion in different softwares. This software is called in vivo software. You have a look at this software nicely. Ask me questions after this session or maybe in between the session, and let me know if you need this software. We have a demo kit for the students where this software is active for 2 months. You can have this software installed on your laptop and play around with it. If you have any plans, if you want to work on the digital imaging systems, you have to work on any or the other software. So it is useful for any department: implantology, ortho, endo, oral medicine, and in fact for the airway treatment also. So let's move on to the next. This is the front view where there are different tools, like this is a distance measurement tool. We can measure the distance. This is the angle measurement tool. We can measure the angles. And the area measurement tool. Suppose we want to measure the area of sinus or maybe the airway. We can measure the area, and the readings are available here. So let's move on to the next tab, which is called volume render tab. We have our skull, we have the anatomy in front of us, and we can apply different tools to see through it. We can we can apply different tools to cut the unwanted part and get the desired results for our diagnosis, for our treatment planning. So we are not we don't want this upper spine. Let us cut it off. So we have tools to cut this part. This is the cutting tool, and I'm chopping it off. this is out, and now we are seeing it from the back side. Friends, I know the software part and you guys know the clinical part of it. You guys know the anatomy. Please let me know what exactly do you want to see in this structure, in this anatomy, and I'll take you there. Okay? Sure. That is in the next part. Yes, we will move on to that. Anything that you want me to, deep dive? You want me to, want me to, take you to that particular section? Please let me know. Alright, so I'll show you some more features. This is the clipping. I have clipped half of the anatomy, and now we are seeing, we are growing the volume, and we can see how the teeth are sitting in the mandibular or the maxillary bone. What is the angulation, how they are placed, what is the width available for the implant. We can measure the width which is available for placing the implants. We can measure the angle of the adjacent tooth. Now let's cut it axially. So this is the axial cut. We can rotate it and we can see it, how many roots are there in a last molar or premolar. We can zoom it to see it in more detail. And this is not animation. I am doing it right in front of you. That is why I decided not to play any video in front of you. I decided to open the actual software and show you how things are changing, how we can give a better treatment to the patients, and how we can be sure before we plan a treatment, before we open the patient's anatomy. Alright, so this was the axial clipping. Now the cornel clipping. We are building it coronally. There are different views. Right now we are on the teeth view. This is the soft tissue view. We have the airway and the other glands available. This is the soft tissue view. With the skin superimposed. This is soft tissue plus teeth, soft tissue plus bone, and this is the bone view. So we can work on any of the views available to us. Wherever we feel comfortable, we can do that. There are set presets. We can rotate the anatomy accordingly. This is how we can work on this part of the software. Then comes the art section. Art section is the tool where you can draw the nerve. Let me show you how we can do it. I am adjusting the field of interest where we want to draw the nerve. Alright, so we have the nerve already placed. Let's delete it and let's do a new nerve. So we have this slice, we have this half panorama with us. Let us first draw a full panorama. So for drawing a panorama, we need a focal trough. We need to draw a focal trough on the axial view, and then we can go ahead for the nerve tracing. So I am doing a focal trough. And now I have a nice pan in front of me. This is the slice view. I can go to the X-ray view. Slice means the slice of the pan. And here I can place my nerve. So let's do the nerve tracing now. We can do it in the slice view or we can do it in the X-ray view. In slice view, we can draw it in a more better way. So let's do it on the slice way. Click on new nerve and keep on clicking, dragging it all the way to the foramen and done. So we have done it. Our nerve is there. Let's see it in the X-ray view, and we can see the nerve nicely here in the X-ray view because this is the pan with the thickness. Now after doing the nerve, we have the cross-sectional areas. There are 2 implants already placed. We can move them, we can reorient, we can replace them. We'll do that in the Implant Planning tab. We have the slices, we have the axial view and the cross-sectional slices. This can be viewed on the software, this can be printed on a film, this can be printed on the paper, and can be viewed in different viewers. Now let's come to the Implant Planning tab. Okay, let's first disable the clipping. So this is another part of the software where we can place the implant. We have the axial view, we have the cornel view, and we have one area where the bone density is shown. And in this view, the colors around the implant shows the type of bone available around it. White is the highest bone density and black is the bad news, or maybe red or maybe orange. That bone may not be good for holding the implant, and then you have to plan something different for that treatment. Alright, so we have our anatomy and we have already placed the implants. Now let's try to reorient, let's try to move the implants, or let us add one more implant. Let us add 3-1. Yes. Okay, I am adding a maxillary implant just to show you how we can place the implants. So we have our implant on the cursor. We can drag it and drop it on the anatomy. Now, as soon as we drop the implant, we have the axial view in front of us to align the implant nicely at place. And the color around the implant shows the bone density of the bone available here. We can change the angle also. We can see what is around the implant, and now that we are not happy because this is very near to the other tooth, we can place it in a different way, and then we can rotate it separately and see what is around this implant, what is there in the 360-degree view of the implant. Similarly, we can do it for the other implants. So now I have this one and I can see how we can rotate this implant. The other one is available in this view. I can move it up, I can take it back, and can you see this warning? Warning sign, warning 0.0 mm. That means our implant is too deep inside the nerve. The software gives us the indication that we are very near to the nerve and we have to move the implant up or down. So let's move it up. Alright, so we are okay with this. So this is how we can place the implants. I have placed it in the 3D. We can place it in the panorama also. Here is the panorama, and I can pick and place the implants like this. Like this. We can pick and place the implants. Okay. So the software gives the wrong ID selected for that particular implant. Then there are different view controls. We can see it in a bone view, we can see it in a teeth view. as you can see the difference here, we can see the inverse because of the brightness and contrast levels. While the PC is connected with the projector, we are seeing everything white here, but actually it will be the inverse of this. The teeth will be black and the other area will be white. After this, let's come to restoration part. And let me tell you, on every part, on every tool of this software, you have distance, angle, volume and area measurement tool. You have cutting tool and video sequence tool. Alright, so now in the restoration, there are abutments that we can place. Matching angle to implants too large, restoration may not match implants. Okay, I'm just giving you the brief idea how we can place these, because there are a lot of implants that we have placed randomly. Now let's plan these two only. Let us move it a little more down and we can align it accordingly. And now this is now ready for our drill guide system. After we plan our treatment here, we can send it in a CD to the milling machines or to the surgical drill guide template planning systems. After this comes the Tmj Planning Screen, where temporomandibular joints can be seen from 360 degrees with open mouth, with closed mouth. These are the different slices. And we can see it in a 3D or we can see it in the X-ray view. So this is the only thing available in the TMJ, but when you explore the software clinically, you have a lot more tools, you have a lot more features available here in this part of the software as well. Then comes the Super Pano, where you have a pan. This is a very special kind of software where you have a 3D pan. You have a panorama which has a thickness, and let me enable the 3D of this, and you can actually rotate the pan and see it from the back side. You can actually cut it down and see how the nerve, let me make the nerve visible, how the nerve is moving in the mandibular bone. And we can see it very nicely in the 3D when we have a 3D pan. And this part of the software is, you know, patented software. This is not available with so many softwares, but with the special ones. And then we can see it in different views. We can see it in teeth view, we can see it in bone view. With this kind of 3D pan, the implant planning is very simple, because we can clearly see the thickness, we can see the depression inside, the angulation here. This is not the case where the implant may perforate, but there are deep angles inside. You know the clinical term for that. There are deep angles inside, and when we place the implant straight, there may be perforation. Then comes the Super Ceph. However, this is not the case of a full cephalogram, but this is how you can get a Ceph for 2D tracing or for 3D tracing. I will not run, or I will not do a 3D tracing here, because that is a long process, but definitely in your demo softwares where you yourself can work, we will share a video on the tutorial of a 3D tracing. Then comes the superimposition software. This superimposition is very important when pre-treatment or post-treatments are compared, or maybe after treatment we give some time for healing or some time for changes, and then we do a rescan or evaluation scan. So superimposition can be important there. I can show you how it works. We have our original volume and we can superimpose a new volume on it just to see the changes. Now you can see the white part is the original volume and the blue one is the superimposed volume. And as I have superimposed the same scan over it, we can see there is no distortion, there is nothing changed, but there will be changes in pre-operative or post-operative scans, or maybe a post-operative and a follow-up scan. So this is how we can measure the changes. Like in the orthodontic treatments, this tool is very important. After we put the braces, after 2-3 months we can take a follow-up scan and analyze the changes. Gallery is nothing but a gallery where we can save the snapshots. These are the snapshots that are saved already with the crown, the model. The model tool. This is the tool where you can actually wrap a photograph of a patient. This is mainly used for orthogenetic surgeries where maybe mandibular bone or maxillary bone is cut, chin is cutted, and the surgery is planned, and the actual photograph of a patient is wrapped over it just to see how the treatment is going to be. What would be the patient's profile after the treatment. And last but not the least, the reporting tool, where whatever you have done in all the previous tabs, you can create a 5-page, a 10-page, a 15-page, or a single-page report for your studies, for your thesis, for the patients, or for other dentists. So this is all about the softwares, my friends.